Okay, we have an exciting cameo presentation. Wow, live in the flesh too. I was not expecting. Parker, who went through the master's program here at DGHI, the accelerated, right? You did both? Yeah. Did I? Okay, because I didn't want to give you the wrong kudos. And did a really awesome thesis project that she's going to share on, which is about hospital-based financial toxicity, which is like catastrophic health expenditures in Tanzania. So without further ado, I will hand it over to you, Parker.
Thank you. Glad I could make it. I was in halves and decided to take a run when we had the sharing in the beginning.
You made it just in time.
Well, hello everyone. Let me turn my video on. For those online can see me. My name is Parker, and as Ashley so kindly introduced, I went through the Master's Program Global Health Accelerated track a year ago, 2 years ago now. I'm now in the second year of med school, and this project has actually been published as of this fall in a paper, which is very exciting. And today we're going to chat a little bit about financial toxicity, as Ashley said, really regarding acute injuries. And then specifically, we're going to use the framework of the 3 delays model, which if you haven't heard before, don't worry, I'm going to tell you about it. You can see all the lovely co-authors here who all put in a lot of work in this project over the years as well. So big shout out to them. So I know we are Gemini and therefore everybody knows about global injury, but I'm still going to give you my 3 points on it. So I love this line. You see it in a lot of the literature, and it is true. It's written over paper. The global injuries account for more deaths annually than a lot of these other hot topic items, tuberculosis, malaria, and HIV/AIDS combined. Now, zooming in more specifically, 90% of global injury deaths are located in low and middle income countries. And zooming in more, when we're talking about the burden of disease, both in terms of deaths and morbidity, the DALYs per thousand are 1.4 times higher in Africa than the global average. So deaths and morbidity. And then in terms of how we get to financial toxicity, it's a very strong predictor in terms of delays of care for those who experience financial toxicity and then later have poor prognoses following an injury. So here's that 3 delays model I promised. So this essentially talks about the delays that someone can experience on their journey to healthcare, their path to healthcare. After injury, in our case, because we're modifying it to be injury. You then have the delay 1, which is the delay in your decision to seek care. To recognize, yes, I'm going to seek care, I need to go seek care. That's the first delay, is that decision. The second delay is actually getting to the appropriate healthcare facility. And I do emphasize appropriate here. It is not just the first healthcare facility you get to, it is the healthcare facility which is adequately and appropriately equipped to take care of whatever it is you are suffering from. This includes transfers from different facilities to higher level facilities. And then our third delay, we have the delay in receiving appropriate care. So once you've entered the doors of that final appropriate healthcare facility, then it is the delay in receiving the actual care that you need. Not any care, but the care that will definitively help you in your injury, in our case. Delays 1, 2, and 3. So in terms of our methods for our study, we did a cross-sectional study. Which leveraged 2 main data sources in our case, which was the prospective trauma registry, and then a combined health needs and financial status assessment. So we essentially wanted to include all individuals who are going to ACMC with an acute injury, so an injury happening generally within less than 24 hours who were adults. We were including those who were able to consent themselves and also those who had a legally authorized representative. Our measures that we use, one of which is catastrophic health expenditure. So financial toxicity is a big umbrella term. And so in our study, we broke it down into 2 measures. First one being catastrophic health expenditure. This is essentially the burden of the healthcare expenditure on what a household has available. Our second measure was impoverishment, which is essentially any healthcare expenditure that pushes a household below the poverty line or further deepens their pre-existing impoverishment. So we're back at that 3 delays model, and specifically we're going to start here at delay 1. We're going to walk through a diagram that's from the paper that I think is probably our most cumulative diagram summarizing our results. So on the left, you're gonna see financial toxicity. These are individuals who had either a catastrophic health expenditure or an impoverishing expense due to their hospitalization. And on the right, you're gonna see the results for those who had no form of financial toxicity at all. The first thing I want to highlight is the number of household dependents. So when we're still in the decision to seek care, there's a lot of factors that have to go into your decision, right? One of which, majorly, being childcare. And so if you look in terms of who these individuals are considering when they are considering seeking care, we have a very large household size in terms of those who have future financial toxicity. So 18.4% and 17.9% respectively having more than 6 dependents. Dependents can be parents who don't work, dependents can be children, dependents can be anyone in the middle who's not contributing to the household income. Whereas on those who have no financial toxicity, these are much smaller households on average from what we found in our sample. And if we look at how much money these households are making, we're talking about monthly income per capita. So the total household income divided by the number of people who are in that household. And if you look, there's a significant difference in terms of who is making more money per person, how many resources you have available per person. So this kind of takes into account both household size and household income to try and come up with a measure of financial stability before you're even deciding to seek care. So there were a lot of factors that we measured, but these are the 2 we pulled out that had differences between our populations in terms of things you're thinking about. You're thinking about, can I afford to go to care? Can I afford to leave my kids at home or my dependents? Who's going to look after them? And these are things that can lead to future delays in delaying that decision when you're trying to get all of these other factors in place. So we're going to build this model out of this pathway to care. And the next place we're going to focus on is this second delay. And so this delay is, I've decided to go seek care. Now, how long is it going to take me to get to that appropriate care facility? And this is not just a health center. In many cases for people with injuries, for severe injuries, this is a tertiary level care facility. So we're back to this diagram again. Financial toxicity on the left, none on the right. And if you look at the first thing we point out is facility transfers. Those individuals who had financial toxicity have many more facility transfers. This threshold we used was greater than 2 in this case, meaning they bounced from one facility to another to then KCMC before they were able to receive appropriate level of care. And that in and of itself is a delay. Whereas if you look on the other side, individuals with no financial toxicity had very few of them who were experiencing this level of transfers. Now there's many reasons for this. And we didn't exactly pin down the reason behind it in this study, but that's an area you can look at in the future. Maybe there's financial stability of being able to skip the referrals process and go right to KCMC. Maybe you don't necessarily have the resources to travel all the way to KCMC in the beginning. So you go to the nearest place you can get. We don't have the reasons, we do have the differences. The second thing we're going to talk about is the surgical burden in these populations. So almost half, anywhere from 42 to 55% of people who've experienced financial toxicity needed a surgery later on. And we use this as kind of a proxy for a more severe injury. And then if you look on the no financial toxicity side, you're in the 10 to 22% range. So these individuals are, number one, not having the cost of surgery, right? Important to consider. But number 2, their injuries do not warrant a surgery. So we use this, again, as a proxy for severity of injuries in the financial toxicity category and the non-financial toxicity category. So again, we're building out this model. And the third delay we didn't find as big of a difference in our study, because we really wanted to focus on the kind of the path to care as opposed to within the hospital door to whatever your intervention was. But what we did find is the difference in the final out-of-pocket costs were staggeringly different. I'm going to put numbers to it. So in terms of the magnitude of difference, for catastrophic health expenditure, the average out-of-pocket, so amount that someone was owed at the end of their healthcare journey, was 5.77 times higher than someone who did not have a catastrophic health expenditure. And for impoverishment, that was 2.3 times higher. So yes, of course, based on the measures we're using, you have a higher expense. You're more likely to be impoverished and have a catastrophic health expense. But this isn't a small difference. This is a significant difference. And these out-of-pocket costs include everything from number of specialists you consulted, number of days you spent in the hospital, level of care you received in the hospital, ICU versus not, number of surgeries, right? And this does not include how much they paid for childcare at home, money they lost because they couldn't work. So this is a conservative estimate, is how I would put it. but still a staggeringly different amount in terms of the financial burden received by a portion of people in comparison to those who have financial stability after an injury. And having an injury is already debilitating enough in terms of recovery time from that. And then add on top of that all these financial expenses, and you can see where we can start to have diverging prognoses and diverging outcomes, both due to household characteristics over here in delay 1, and then actual injury path and facility characteristics over here in delay 2. So to kind of summarize what I'm saying here. In delay 1, right, this delay in deciding to seek care, we see these households who are financially constrained at baseline, with less money per person and more mouths to feed, more dependents who are depending on these household breadwinners. And this, from the literature, we know that financial distress and these concerns for additional expenses can lead to delays in care, due to considering the income you're gonna have to forego, considering the childcare that you're gonna have to go get. And so with all of that in mind, we see these financial constraints, these household characteristics at baseline before anybody has an injury, and more dependence leading to a prevalence of financial toxicity in those households. And we wrap that up under delay 1, deciding to seek care. And for delay 2, after they actually decide to seek care, regardless of whatever delays they've had beforehand, these individuals with this financial catastrophe and toxicity are having more facility transfers and having a higher surgical burden, implying that they are either A, not seeking care at their first location due to transportation constraints or injury constraints, regardless of what it is, and having more severe outcomes in the end for the surgical burden. And we know, again, from the literature, that these patients who undergo hospital transfer after transfer have a higher odds of in-hospital mortality. So these individuals have a higher odds of dying in the hospital after their injury, as opposed to those who directly seek care at their final appropriate location. With this, we wrap up under delay 2, right? These characteristics of individuals who have more facility transfers, higher surgical burden, greater injuries, longer delay, delay 2, getting to an appropriate care facility. I'd be remiss if I didn't be upfront about the limitations of our study. So we had what I would sum up as an underrepresentation of some of the most severe cases of injury and financial toxicity. So these are those individuals who never made it to the doors of KCMC because they died at a previous facility or died en route. And this also includes individuals who never sought care because the burden of cost was so high, they chose not to go. So we are underrepresenting, notably, our cases of injury and financial toxicity, and yet the burden we found is still so high. And I'm going to hit on that point again when we're talking about our out-of-pocket costs. Like I said, this only includes costs from the door to KCMC onwards. So all of those costs in transportation, whether somebody had transport, it was public, private, ambulance, to a previous facility, all of that is not included in this current study. And so our final costs are also underestimates. So the burden is likely far higher than we found in this study. And then kind of finally, we had some time to care variables that were self or family reported. And when you're suffering from an injury, there's likely to be some dilation of time with that. And so we definitely have a potential for recall or information biases here. But even still, the numbers speak for themselves in terms of the cost burden that these individuals are suffering and the delays in their care, potentially, with differences in morbidity and mortality. So in terms of where we want to go with this. So there's National Health Insurance Fund. Another thing we found is 84% of these individuals of the total subsample, not even split out by financial catastrophe, are underinsured or uninsured. And so expanding the NHIF, the National Health Insurance Fund, with additional protection for these acute injuries and other emergent conditions could facilitate that decision to seek care, could reduce that initial thought burden of where is everyone going to go, how am I going to afford this? Additionally, because these individuals are at risk prior to even suffering an injury or delay in care, we would advise systemically focusing interventions on those at-risk households. You could use factors that we use, you could use other factors in terms of low monthly income, low per capita income, high numbers of dependents. But these households are at risk not just for injury, but for any catastrophic expense of any healthcare kind, regardless of what it's due to. And so systematic interventions to focus on those at-risk households would definitely be warranted in reducing that ability care. And finally, when we're talking about pre-hospital delays, right? Because so much of this path to care is before they even hit the doors of their final hospital. Things like emergent transportation, right? Having a pre-hospital network of ambulances, for example. Or you can have expansions of specialized surgical interventions. Not everybody needs to go to KCMC for everything, if you can expand surgery down the line at other healthcare facilities. And so, all of this in mind, we have other work going on in this qualitative study, kind of going into this and looking into this. But there's a lot to be improved upon here in terms of delays to care, and a lot that still needs to be known, right? So with that being said, new references. And many more. My 40-page thesis. But if anyone has any questions, please feel free to ask. I'm more than happy to answer them.
Well, yeah, in all ways. What other questions do you guys have?
Parker,
So-
I have a question. Can you all hear me okay?
Yeah, go for it, Anna.
Great presentation during your thesis. It's nice to kind of just have a reminder of that data again, because I think it's so important. I think you brought up a really important point, though, in the discussion, mentioning that not every patient necessarily has to receive the care at KCMC, right? So your sample are the ones who required that care at KCMC. So I think it's important to note also that there probably are a lot of injury patients who went somewhere else and had the care that they needed there, right? You're really looking at those who needed to be escalated to KCMC for that more specialized care. And I think sometimes it's important to keep that in mind with KCMC being the referral hospital that it is, that we tend to have patients, at least that's what we've seen in the readmission study, the patients that live close by, they come to KCMC. They may not need to come to KCMC, right? And they increase the burden on the hospital system there. So I think that's just an important point that you just mentioned in the discussion. I wouldn't say it's a limitation, but it is a point to make that those were the patients who went to another facility and then had to come to KCMC. And we're not capturing those who received the appropriate care at lower level facilities.
Yeah, that's a great point. It's definitely the sample size, the sample itself is biased towards those who have severe enough injuries to warrant KCMC, or those who were local, who preferred to go to KCMC over somewhere else.
One of my questions is, we think this is an underestimate, right? How do we demonstrate how much of an underestimate this is so that we can continue to make this argument that this is hugely impactful? Number one, and then number two, the cost of doing things at KCMC might be different from elsewhere. And so as we start to think about optimizing healthcare costs and utilization, how would you go about thinking through that process and doing that kind of a study?
So I'll start with number one. In terms of how to understand if this is an underestimate and how to quantify that, I think you can go one of two ways. One, collect more data and better data is the first way, right? Expand to other facilities, capture and follow patients along their path to care to understand, develop better methods, whether that's qualitative or a better survey, to capture all of these other costs in terms of foregone income. It would really be more of a tracking person over time. Number two, you can do a model, some sort of modeling study, right? Where you're predicting based off of similar context for a person with that injury in those situations, based on all their demographics, what those factors would look like. So I think, in my mind, and I defer to Emily every time, in my mind, I think those are the two ways you could go about it. Bigger, better data, or a modeling study to quantify the underestimate that we're seeing here. In terms of how do we optimize then healthcare delivery, I think the best way to do it is idea and information sharing. And I think that is something that you have to incentivize people to do, right? Because healthcare is at the end of the day still a business. People still do want to make money. I think we need to look at where is money going and how does that impact outcomes in order to understand if it's a good spend. And that's something that you can see in other places in the literature. Oh, you've saved X number of dollars per dollar spent. And that tends to motivate administrators and people with money very well. So I would say that would be one of the ways, right? Then you get into biases on like, well, you're prioritizing really common or really severe injuries over those that are rare and they have really big impact on people, turning people into numbers. But at the end of the day, I think that's probably a first step, is understanding where's the money going, how is it directly impacting patient outcomes, and then what can we do about that in comparison to sister institutions in the same context.
Really interesting, because it makes me think, because we're doing a lot more outside of KCMC now, and I know that Liz was on for a little bit. I don't know if she's still on, but really thinking about the outside hospitals that are starting to see trauma patients. And is just a little more capacity building at those outside hospitals going to be better?
Yeah.
Or that transfer, right? And so that question starts to become really interesting when you think about the burden of transfer, both on the patient and on the healthcare system, and sort of the financial cost of a little bit of capacity building in multiple sites.
Yep.
So it's an interesting thing to think about.
And I think to emphasize not just site-based capacity building, but network-based capacity building. Because something we've seen in the preliminary qualitative results is transportation is a massive barrier.
Yep.
Whether that's accessing a form of transportation or receiving an appropriate transportation for the injury that they've received. I think in the absence of a really strong pre-hospital transfer environment, that you also then see those glaring gaps where a facility may not be enough.
And your data shows that. I mean, the biggest burden is at the community level, right after injury.
Mhm.
Yeah, so how do you intervene there? Because yes, it is transport, but it's also stuff like a monthly wage, like a universal, and I mean, they're talking about that from a UN level. I mean, it's gonna be years before that's actually passed. That to bolster the entire community so that at least that first delay is not as bad.
Yeah, I mean, I could happily get into talking about universal basic income and the impact that it's been shown on a small scale to have in communities in terms of care seeking behaviors and improving and reducing delays to care. I think there's definitely multiple levels to intervene here. There's easier ones for us to see based on our position, and there's more difficult ones for us to see and execute from our position. But I think that also means we have multiple actors involved at all these different levels, which can share that burden of kind of improving everything as well.
So speaking of multiple different actors, so Mac is a pediatric emergency medicine physician, Cincinnati, is turning in with Gemini Mentorship a HBNU grant for a year in Tanzania to be able to take a look specifically at transport for peds and adults. I guess we just do both, we might as well. Literally just start to think about that, what you're talking about, like not only like, who do we transport? What do we do when we transport? Do we actually do something intra-transport? Like, will they require medical stabilization? And how much does that all gonna cost? Like, what are we gonna look at in that whole big picture? So I think I might put him in touch with you, if you don't mind, Parker.
Totally.
Because I think it'll be an interesting connection for him to start to think about, from your perspective, what you saw and what that looks like. He's also working with Liz Keating, who's doing the pediatric stuff. So
Cool.
very cool. It's really cool how we can start to get different people at different phases of the process and get everyone to work together. I think that's really interesting.
I just put his
Great job.
name in the phone, but thank you.
It's awesome. I see a comment from Annapurna that I'll read for you guys. The first delay in making the decision to receive care. I guess that's the biggest obstacle, because sometimes people do have those prejudices and biases that affect their judgment when it comes to receiving care. It's not easy to change a person's thinking after all. And as someone who's studied health behavior, that is true. Like, we know sometimes when the solution is so simple, it's because behavior change is not so simple.
Yeah. But it's even at the basic level of knowledge, right? So
Yeah.
health literacy is a very interesting thing in many situations. I even saw it this weekend working, that the level of health literacy of patients, even here at Duke, is incredibly variable. Whereas somebody might know that they need to go to the doctor because they have chest pain, and somebody else might think it's the weather change, right? And they both are having a heart attack. And they both should have been seeking care at the same time. And even that basic amount of knowledge, and it doesn't have to be a bias or prejudice, it can really just be a lack of knowledge or understanding
Yeah.
and a very little health literacy because we're not teaching people what we should be teaching them.
I think also beyond health literacy, I think there are people who have health literacy who do not have the resources and are being delayed. And I think if we start to chip away at those individuals who we can impact, we can narrow the population, and then we can start thinking about, okay, do we need to do a health literacy campaign now, right? And then for something like cancer work, do we need to do a specific campaign on stigma? Right, so I think if we start moving towards that as well, because we know that these are burdens, we'll continue to uncover more burdens as we reduce the ones we know about.
Yep. 100%. This is why you have multimodal interventions, right? You can't just hit one area or else you'll be left with 10 more barriers.
And then have a good statistician on your team who can disentangle what made
All
it
of
work.
it. Yep,
Yeah.
exactly.
Figure it out. Parker, my question to you is not necessarily related to this. When you got the reviews back for this paper, they were wonderful. And it was almost like you don't need to do anything substantial about this. That's really rare, especially as young as you are in your career. So what advice do you have for the rest of us? How do you write well like that for a reviewer? How did you learn that?
That's such a great question.
What do you have to teach us?
Yeah, I think that's such a great question. I think the answer is twofold. One is that as good as I am not as good as a team. And I think that's first and foremost. The number of eyes who looked at this paper was incredible. And I think that really helped polish it, right? Leaning into the experience of mentors, whether that's how do I talk about this measure I've never talked about before in a way that makes sense, right? And explains it, but also is like on par with literature. And I also think beyond that, there's a lot of like, you hit a wall and then you go digging. And you hit another wall and you go digging again. And then you find a new wall that you didn't know about the first time because you went digging and you're like, okay, now I need to go back and rewrite. I think being willing to make changes is hard, especially when you've put so much time and effort into something. And then being willing to go back and be like, I do in fact need to rewrite this chunk because of this new thing that came out or because of this new feedback that I've gotten. I think was also really helpful in helping this paper and this project become its best form. I think those are two pieces of advice I would give.
I love that. From an outside perspective, like working with you, I think your ability to pivot and curiosity, I think that just made the writing process easier and it really paid off when you just published it. Thank you for answering that.
Thank you
Awkward
for asking
question.
such a nice question.
And persistence, tell us about your story in the publishing process, because that was also interesting.
So this paper was submitted to a couple places, which is common, not abnormal. This paper also was in processing for a year and a half. And that included being with the same journal for at least half to 3/4 of that time. Trying to follow up on reviewers and being like, hey, can you please assign reviewers to this? Or getting feedback back and then submitting it within 24 hours because as soon as I got reviews, we're submitting it again. And then another delay of, another delay of more reviewers, we're waiting for more academic reviewers. So I think, again, leaning into the advice that I got, asking when I was like, I don't really know a lot, but this feels like it's been a long time. Like, what should we be doing about this? Should we go back and ask for a reconsideration or rejection? Should we go back and, pester the academic editor politely and professionally to assign reviewers to our paper? I think not being afraid to speak up and not being afraid to ask the question of like, I'm not an expert, this is my first paper, but should things really be taking this long? I think those were helpful in the long journey that it was.
I think your statement specifically, you glossed over it, but I think it's really important. Your polite reconsideration of a rejection, I think was really important. When you know your work really well and you're reading the reviews and they're just, I didn't change very much. Why are you rejecting me? Stand up and have a voice for your work. Worst thing they can say is no. But then it's really obvious, like you rocked it because you got nothing back on the final reviews, right? And so sometimes some people just are gonna make a mistake. And so a polite reconsideration is always a way to go. So.
And to have a team where you have someone like Catherine to go, hold up. Like, that's not a true rejection type.
Let's argue this because we can do this.
It's very easy to undervalue your work when you're early in any career. Because I think I know the project very well, but I don't know how it compares. necessarily to other projects of other calibers. So I think that's also very helpful, surrounding yourself with people who are at different stages.
Very cool, nicely done. Lots of academic lessons to learn.
Well, I'm quite sure we could stay and talk about this for a very long time. Something I know that Parker has probably spent way too many hours thinking about. But let's again thank Parker for a great job and good luck on what's next.